Well, hi, everyone. My name is Lynn Crawford. And most of you know that we've had a challenge getting today's meeting going, but we have guests here that we will owe forever because we call them up on the phone and they say, well, yes, I can do that. So here they are. And Sue Doyle, who is an occupational therapist, and Sam Lewis, who is a medical social worker, who also is the manager of the CARES program, which is a very special program from Clark County Fire. And I'm going to let them talk about themselves a little bit.
All right. So I'm Sue Doyle. I'm an occupational therapist. I've been an occupational therapist 42 years now. So that might age me a little bit. I, for the last 7 years, have been running OT Lifestyle Solutions, which looks at home safety, home modifications in the Clark and Cowlitz County area. So that's the short synopsis.
Wonderful. I'm Sam Lewis. I'm a social worker with Clark Cowlitz Fire Rescue, which is the fire district kind of north of here in the center, Richfield and Woodland. We are part of our CARES program, which is our community kind of education program. So we'll do kind of a non-emergency calls and follow-ups with folks who might be using the system for a variety of reasons, which we'll go over. I've been in the field of mental health and social work for, again, probably about 25 years now. So I'm a mental health professional and social worker.
So I thought tonight we'd talk a little bit about falls in dementia and just kind of go over some of the highlights and then some of the things to do to look at a dementia-friendly home. And so if you want to move on. So as we talk about this, I want you to also take into account that there's a lot of variability. Everyone is somewhat different or has a different past, interests, hobbies, those kinds of things. There's no clear, reliable way to tell how the disease is going to progress, as you were aware of. Everyone is slightly different in that. We know there's memory impairments, executive function impairments, decreased judgment, changes in personality, and changes in wake sleep patterns and schedules. And so those are going to impact safety, obviously. So as we go to the next slide, one of the things to take into account is that people with dementia have almost 8 times the amount of falls that other seniors do. And so that's significant when we look at it and we look at the cost of falls as it is. And now we think about, once you have someone with dementia, it's 8 times. But even more significantly, they're 3 times more likely to fracture their hip. And so there's significant things related to fracturing your hip. One, decreasing mobility long-term, decreasing your lifespan and life expectancy long-term as well as the pain and the cost that are associated with that. So obviously we want to reduce those falls. So if we go to the next slide. The other thing is people with dementia recover less well from a fall than people without dementia. And people with dementia who have a history of falling are 5 times more likely to be institutionalized than people with dementia who don't fall. Falling and repeated falling is a key indicator of somebody being placed in a care facility. Fall prevention strategies that work for people who don't have a cognitive impairment don't tend to work and are not successful for people who have a cognitive impairment. So we need to kind of change up some of our strategies and advice. It doesn't work as well when you can't process or think through. All right, if we go to the next one. So of course, the general risk factors are those associated with aging, which all of us, unless we are looking at alternative existence, are experiencing. But the risk factors that are unique to people with dementia include that verbally disruptive and attention-seeking behavior, those cortical changes, the severity of the dementia, some of how our eyesight and our depth perception and that is working. Also the impact and the interaction between the person and whoever's providing care. And then the fatigue and the effect on the caregiver as well, which you're all very aware of. If you have Lewy body dementia, then it's more likely to increase your risk of falls than having Alzheimer's. And then a history of falls within the last 12 months, of course, is going to increase that risk. And as we were just talking about, it's usually more than one fall. If you've got a history of falls, it's usually multiple falls in that time period. Also, something that we don't always notice, particularly in someone with cognitive impairment, is that orthostatic hypertension. And it often goes unnoticed because they can't verbalize that they're dizzy when they're getting up. And so just looking at that, and then autonomic symptom scores, that have to do with how the body's processing all those automatic things that are going on, not only monitoring our blood pressure, but monitoring our heart rate, monitoring our respiratory rate, monitoring our pain sense, monitoring our body temperature. That can get disturbed as well, and that impacts safety. And then depression, which is a key factor associated with that. And depression by itself is associated with increased risk of falls. So, then you add that with dementia, you're increasing the risk again. Next slide. So we're seeing things like weakness and gait changes, decreased balance, lack of physical exercise. It's hard to get people motivated. It's difficult to keep up the same thing. The level of burden of caregiving has changed physical habits, usually within the whole arrangement, because of that exists within that household. Memory impairments and poor judgment. So being able to remember, did I exercise? Oh yeah, I went, and it was a week ago, but still not being aware of that. Again, like I talked about, those visual spatial impairments, thinking that dark spot in front of them on the carpet, which is a rug or whatever, is now a hole and they can't walk around it. So those kinds of things, fatigue, of course. Then the side effects of medication, which is a really significant one. Clutter. Clutter tends to come about because they can't put things away, or things are difficult to rearrange. They want things close or nearby because they're afraid if it goes away, they're gone. So managing that, restlessness, hunger and thirst, not being able to understand that a meal's coming or a drink's coming, and going looking for it, pain, discomfort, boredom and loneliness, and then that urgency for going to the bathroom, and particularly through the night with that option. All right, the next one. I'm going to just do a little bit of some of the research just because it helps us understand a little bit about what's going on. When we look at some of the studies, we see that if you're male, you're more at risk for falls in most of the studies. That is not always true. Interestingly, the studies tend to indicate that men tend to fall outside the home more frequently than inside the home, and women tend to fall more frequently inside for some reason. Some say increasing age, some say not. It's more the severity of the symptoms. And so I think that's unique. Balance impairments, of course, are associated with falls. There's one that's there we think about when we're looking at balance impairments and strength. We think only about legs and lower extremity strength. But in fact, several studies have said that arm strength is a key predictor as well, because it's a predictor of overall strength and impacts balance. But also, if your arms are working well and you've got good strength, you're more likely to prevent yourself from falling by catching yourself and having a near fall versus a fall, or more likely to be able to safely use a mobility aid. The use of the mobility aid, of course, increases falls, particularly amongst men. Slower walking speeds, decreased stride length, of course. And that base of support is kind of not knowing where midline is when you're sitting upright. You tend to lean or fall, difficulty maintaining that. Walking outside was associated with risk of falls, and why do we think that is?
Uneven ground.
Uneven ground, absolutely. And then the other thing is often shadows and things like that that affect that depth perception. And then, that cognitive and visual perception impairment, as we said there. So the research is telling us all of those factors. And if we look at those are all things that are associated with progressing symptoms of dementia. The next slide. The other thing that we see is difficulty getting up from a chair. And as we start to see that occur, we need to address it as soon as that becomes a problem. Dependency with hygiene. taking 4 or more prescription medications. I think I saw some study that most people over 50 are taking 4 medications. So that puts a lot of people in that. I don't know about that because I don't, but as we look at aging, we know that more and more of us are taking medications for some things that puts at risk. And if we have a diagnosis such as dementia, then we're likely taking some medications for other things as well. And those medications interact. So really having a conversation with pharmacy and a conversation, and I know, I think you guys do some of that screening on that at your doctor's office about what medications are really essential to be on. Increased anxiety and increased impulsivity, those impact judgment and also put us at high fall risk. And then the severity of the dementia. Again, the studies are showing mixed results. It really is a combination of all those factors. And it's really hard to predict with one person, but it's very obvious when you're there and you're seeing it. Okay, next slide. I just put this in because there was some studies looking at COVID and dementia. And so the long-term effects appear, and I mean, long-term, we've only got a couple of years of data to increase the incidence of Alzheimer's and other dementias. And what they're thinking is as we age, our brain doesn't have as much resiliency and we have this viral impact on our neural functioning. If you look at people, even younger people who are experiencing long COVID, brain fog, decreased thinking speed is all part of that long-term COVID. So there is some thought that this may be part of a brain inflammation type of process. There is some ataxias and some altered mental status. And then the other thing that's interesting is the higher number of CVAs in the first 2 weeks after symptom onset, and then a new onset of seizures.
So explain ataxia and CVAs.
So ataxia is where your balance is off and you're kind of walking like you're somewhat drunk. And then CVA is a stroke.
Okay.
So there's a higher increase of stroke. The other thing is we are seeing with the multiple vaccinations, some higher increase of stroke as well, and we're not sure what the association with that is in the data. People with dementia have increased incidence of delirium and when they get COVID, and this seems to continue and persist. So there's some primary features of encephalopathy, and then the virus acting on some of the nerves that go into the brain and out to the eyes or some of those areas that impact. So that viral neural invasion that we're talking about. Persons with diabetes also have an increased incidence of severe COVID. And then of course we know hypertension is associated, and both of those factors alone are also associated with a higher incidence of dementia. So you can see that these things can all interact together. In an early report, and we put the studies there, found that 1 in 3 individuals who were hospitalized for severe COVID-19 actually had, it says, dysexecutive syndrome at the time of discharge, but that meant they had some higher level brain thinking impairments in terms of making judgments, looking ahead, being able to plan and predict, which is what that executive syndrome is. And so you can see that if you have someone even who is just starting to have dementia and they get a severe case of COVID, you're going to see some of these symptoms get exacerbated as well. Delirium is likely a sign of infection, and the risk of poor outcomes and mortality is higher. And then the other thing we know is intensive viral infections do exacerbate or increase that neural decline. The other thing, and this has been the saddest thing, and this has been the thing that I've seen the most over COVID, is that it's contributed to an acceleration in the progression of dementia and an acceleration in the number of falls that my clients are having. I don't know if you guys have seen that too, but we've seen this big increase in clients who are falling and have gotten weaker. They're not going out for walks. They're not walking in the shopping centers. They're not, and that has really led to that.
Yeah, we haven't seen it with the correlation with the COVID, but that's interesting.
Yes, I'm on service. We talk about it. Our patients have been getting weaker, just not going out and not doing things because of the isolation or trying to limit their risk of infection. of course, we had this discussion, and I'm not going to go into this right now because it's not the topic, but just thinking about, is a person safe to be left alone? Occupational therapists can do an Allen cognitive level screen that gives us some indication of that. But just that whole thing about the person's best interest and the ability to take some degree of risk. And thankfully, stupidity isn't quite illegal most of the time, because I probably would have to have owned up for a few things like that. But I did have to fess up to my kids that mine were all sober, which they laughed about. But thinking about weighing up the risk and what's an amount of risk and where they have a choice for risk and where the family unit has that choice for risk. Discussion for another day, but there are some checklist options available. Therapists can do a bunch of different assessments. I know you're going to talk about the STEADY assessment. We use the STEADY a lot, and being STEADY certified. STEADY recommends that if we have 1 to 2 falls, 1 with an injury, 2 within a year, that the person be assessed by a physical therapist for balance, an eye specialist, review of medication, and then an occupational therapist for a home safety assessment. And there are some of the assessments there that a physical therapist can do that work in dementia, looking at mobility. And then the next slide. And then there are specific home safety assessments now that are designed and have been researched for people with dementia. And they really identify fall hazards, adaptations, cues that are needed, whether they be visual or whether they be environmental in a different way, or whether they be verbal clutter, and then the comfort and familiarity or habits and retraining with them. And it just gives you an example of the checklist, and it's scored. I just thought it might be interesting, but it goes through every room in the house looking at options. Then we come up with a score and prediction. I know Laura Gitlin, the researcher who did this, and it's really, there's been about 10 years of study on this for persons with dementia in this population. It's a really good predictor in looking at outcomes. And it just kind of gives you, then what would we do looking at, do we need to adapt for the hazards, adaptations, or cues? So questions to consider when you're also doing this that don't necessarily show up when you're just doing a plain assessment or talking to someone. Do they become confused or unpredictable when they're stressed? Because stress is a panic thing, or for all of us, we can become a little confused. Recognizing a dangerous situation, knowing how to use the telephone in an emergency, and I put it there twice, it must have thought it was really important. Know how to get help, and how to stay content in the home if no one else is there. Do they wander and become disoriented? Because that's another big key. We were just talking about that earlier. When people wander, the risks associated. Show signs of agitation, depression, or withdrawal when no one's there. Attempt to pursue former interests or hobbies that may warrant supervision, such as cooking, appliance repair, woodworking, getting out the electric drill, going for a drive in the car. So all of those kinds of things are things to be taken into account. And so general principles are think prevention and planning ahead to be prepared. Keep the progressive nature in mind, but focus on the current needs, and then adapt the environment. Environmental adaptations are often easier than behavioral adaptations, because it's really hard for all of us to learn new habits and new routines. But in this situation, when your executive function isn't working well, then it's even harder. Reduce the needs for medications with the environmental adaptations. In fact, several studies have shown that if we have an accessible home and we've changed those environmental adaptations, we can decrease depression significantly and reduce medication. And we can also increase overall cognitive functioning. So thinking about how we can do that. And then a safe environment is less restrictive, but allows participation and engagement. And really having people still be engaged is really important to prevent that ongoing decline. Okay, well, reduce it, maybe not prevent it. So some of the general home safety considerations that we recommend, and I'm just going to go through some general principles as we work here, is display emergency numbers in your home address near all telephones. If you still have a landline, or even on a cell phone, make sure that you turn the answering machine on really quickly or turn the ringer down, because that creates confusion, distraction. But has everyone ever experienced, how often do we let a phone go without feeling that urgency to answer it, right? And particularly the older generation like me, because my teenager, my kids can just ignore it, but they're used to a million things. But the rest of us, we have this urgency because it was rude not to answer it, right? And we need to, and so that also is that sense that comes through with someone who has dementia and maybe some decreased mobility. So we want to reduce that. Have safe locations for cell phones and portable equipment. And what I mean is make sure that you have somewhere that isn't able to be carried off somewhere that you can never find it again when you need it for an emergency. Have working smoke alarms and carbon monoxide detectors. That is really key to give you that first alert. Store volatile liquids, poisons in locked locations. Install secure locks on outside windows and doors. Hide a spare key outside in case the person with Alzheimer's or dementia locks you out. That has happened multiple times before. So, general safety considerations: avoid the use of extension cords, especially for lamps. Someone's going to trip over them. Cover unused electrical outlets with childproof plugs. Use red tape around floor vents and radiators to deter the person from standing on them or touching them. Because red is a warning sign for us, and it tells us it's hot. That's our innate response to red. That's how we've been conditioned. And so they're more likely to, move away from it than touch it. Adequate lighting in all rooms, hallways, and steps. If possible, use motion detecting lights in the hallways and steps. There are great options now that can plug in or not plug in and just be attached on the steps and in the hallways. There's some nice LED lights that you can set up for motion detecting. In a lot of these options now that they're becoming more commonplace are not that expensive, which is really great versus even 5-10 years ago. Next. Stairways should have at least one handrail that extends beyond the first step. Looking at a non-slip surface on the steps, like a carpet, place gate on the steps. A gate as in a GATE on the steps if a person has a balance problem. And because you don't want them going up and down the stairs. So using a gate or a baby gate there. Lock medications. If they're home alone and need to use it, have a time dispenser with alarms so that they can only take a certain amount at a certain time. Keep alcohol in a locked cabinet. It increases confusion, impairs balance, judgment, and safety. Monitor smoking if they're smoking, and remove matches, lighters, and ashtrays and cigarettes away from view. Clutter, again, for any of us, it leads to confusion, but in this situation, it increases anxiety and it increases the danger of falling as well. So you want to keep all the walkways free, keep plastic bags out of reach. Remove guns or other weapons, store in a locked storage area that they don't have the ability to access, that it's a new code or it's a new locking system, so that remote memory doesn't cut in. And then remove the ammunition and the firing pin or have a safety lock. And then lock up power tools. Because it's interesting, people go out there and try to drill something or cut something with a saw, so you want to keep those away. Remove poisonous plants, one we don't often think about, but a lot of our indoor house plants can be poisonous. They can be mistaken and eaten. So just looking at ones that are poisonous and put them away. The other thing is make sure that any of your important information, if the person is used to using the computer, is stored behind a separate locked password so that it can't be deleted or removed. Use screening software to reduce the time and online access. Keep fish tanks out of reach, including the chemicals. People have eaten some of those. Interesting paint colors have a lot to do with how we react and respond. And so blue is a restful color. It has a calming effect, can lower blood pressure, makes the room feel more open and larger if it's a lighter blue, not a dark blue. Red increases brain activity and focus attention on the item. It also perceives the temperature in the room and can indicate that it's hotter. Green is a restful color. It reduces that overall CNS activity and helps with calming. So thinking about when you're looking at these, if you're wanting someone to be more active and alert in a certain area, you may want to look at how the colors work together versus if you want it to be a calming, restful, sleeping situation. So lime green, for example, cues in the bathroom, the bedroom, and the walker because that really attracts that attention and it's effective to do that. Pink can also be calming. It's often used in prisons where people are exhibiting aggressive behaviors because it's known to be calming. It can have the same effect on all of our brains in that situation. Using contrast is really important to mark edges. So for example, drawing attention to furniture so that they can locate it to sit down, locating items on food, so having it on a contrasting plate. We'll look at contrasting on the toilet soon, defining objects more clearly so that the light switch is a contrast color to the wall and stands out if you want them to use it. If you don't want them to use it, then make it the same color as the wall. Differentiate between horizontal and vertical surfaces. And so even on those pictures, one up on the left, you can see the wall is a different color to the skirting boards, which is a different color to the floor, makes it stand out. Often we will do the same color because it's more, class calming, but if it's the same, then they can't tell the difference. The other thing is really be careful with carpet patterns, especially checkered, because now this is different to if someone has Parkinson's because you want that to improve the gait. But in this situation, it's checkered. One of the checkers becomes a hole and it helps them stop and they don't move forward from there. You can use colors to highlight steps and ramps. Use the same color for flooring that's on the same level. And then if they're moving to the same level, so we're doing a transition from, say, a tile to a carpet or from a hardwood to a tile, you want those thresholds to not contrast, where often you want it to continue at flow. Next. Outside the home, you want the steps to be free of leaves, moss, ice. Ice would be nice right now, though. And you can look at ways that they've highlighted it there so that you can see where things are. And so it's aware, particularly if the person goes outside in the dark or you're coming in from going out at night. Mark the edges with bright or reflective tape. Consider installation of a ramp. And that comes to at some stage where the person is going to be dependent on a wheelchair. At some stage, you're going to need a step-free, barrier-free entry. So if you're going to make changes, consider a ramp as a change to make right up front. Restrict access to pools. Secure the grill and fuel sources and fire starters so that they're behind a locked area so they don't automatically go out unsupervised and set up the grill and then it becomes too big a fire, or the turkey boiler or something like that. Outside the home, again, uneven surfaces. You can see that pathway there is just an accident waiting to happen for all of us. And when your depth perception is impacted, even more so. Peak plants trim back, and that's really hard. And I know that the CDM Living with Dignity program was at some stage helping with that. Some scout groups will help with that because often you're so busy caregiving, being able to keep up with the gardening and everything else is important. Improve lighting, use automatic lighting where possible. Place a bench or a table near the entry door so that people aren't struggling and if they're carrying something in, they can put it down to open the door. And then place a no soliciting sign on the front gate or door. In the kitchen, remove scatter rugs and foam pads from the floor. Make sure the floor surfaces are even and non-slip. Use stove shutoffs and microwave shutoffs. Those are easily available now. There's a couple that if you're not there, if it doesn't detect movement in front of the stove for a certain period of time, a couple of minutes, it will automatically turn the stove element off. There are other ways that those work as well. Lock away sharp items and flammable items, and lock away a cabinet that has breakable or valuable items that you want to keep. If you have grandma's heirloom stuff, put it away somewhere else. Remove artificial fruit. People have tried to eat it, and food shake magnets. Clean out the junk drawer and remove anything that might be a risk, and just leave some things that they can rummage through there that are safe. Use a sink drain to catch anything that might be placed in the drain, and disconnect the garbage disposal because it's not the first time somebody's gone trying to fetch something out of there with it going. Red or blue colored plates offer contrast to food colors. Red may stimulate the appetite, or yellow can even encourage finishing of food. So there's several studies that have been done on that. If the goal is to increase food intake, studies show that using a larger plate in a contrasting color to the food tends to do that, because often people lose their appetite or what they're eating. And so here's some ways to do it. Use tables with round corners versus the sharper right-angled options. Bathroom. This is one of my favorite areas. Actually, in reality, we think that most of the falls occur in the bathroom. They do not. In fact, the data shows that most of the falls occur in the bedroom and the living room. Bathrooms are close second, but it is an important one, and falls here are high risk because the surfaces are often harder, you're wetter. There's a bunch of different things going on that could lead to injury, smaller spaces, etc. Make the changes early is what we're saying, so that the person gets accustomed to them while they can still cognitively process what's happening, and it becomes a routine and a habit. A roll-in shower with non-slip flooring is an ideal option to move towards. A wet room with a consistent color or non-slip floor. Avoid dark colors, as that may be seen as a whole, particularly when you've got the dark tile, light tile options. As all flooring, think about having a matte finish. We've been putting in those, hardwood floors or those LVP flooring, but if it has a shiny finish, that glare adds to the changes in depth perception. You can't think, so you want to go for a matte finish. Flooring with flex or pattern could be perceived as dirt that needs to be picked up, and fall risk again. Breathable shower curtain, so that you're reducing the risk of someone smothering themselves in there and can't get out of it. Automatic water shut off after 30 minutes. And there's lots of automatic water shut off devices now that will allow that. Anti-scald devices versus hot water temperature lowering. Due to memory, focus on familiar fixtures. Avoid rain head showers because you don't know where the rain's coming from, and it's surprising, can be upsetting. Sensitivity increases, so adjustable flow shower, adjustable softer lighting. Lighting in the shower area, though, is important. Avoid use of sharp edges, and tap covers or faucet covers to improve safety. So if they fall, there are several adult ones that are available now, not the kiddie animal ones, so that it looks more grown up and age appropriate. Different colors to define things, and one of these is looking at the contrast with the toilet seat, so that and the toilet bowl, so that the target is clear. Shower chair color that's contrasted with the shower. Toilet paper holder again, and grab bars should be in contrasting colors. And this is where I would use the colored grab bars. There are tons of nice ones available now, particularly if you have dementia or low vision issues. You want these to be really obvious, and you want them to stand out. I also would change all the towel racks out to be actually towel rack grab bars, so that the tendency is, and I've had many clients, I don't use it as a grab bar, but it keeps coming loose. This is the third time they've replaced it for me, right? Yeah. There's some handouts on creating a dementia-friendly bathroom, but those are the things I think you can work with the therapist as well. Removing the locks from the bathroom door so you're not locked out and they're not locked in. Like we were just saying, I had a lock fail with a client of mine that had to call the fire department to get him out of the bathroom. Yeah. Remove cleaning products from under the sink. That's where we all have them, right? The toilet cleaner and the other stuff. Either have a lock on there, childproof lock, or remove them and put them in another area. Motion detecting night lights, there's some great ones out. If you need it, a disco, there's a disco light that goes inside the toilet ring. That is cool. Some people will tolerate it, some not necessarily. But it's worth trying. They're really cheap too. Remove small electrical appliances, particularly if they're associated, on the vanity around the water, and there's a risk of them going into them. Dementia-friendly, I'll try to give you time. Identify the door. If you want them to find the door, right, in and out of the bedroom, identify the door with paint and a sign. So you're looking at contrasting covers. Contrast the bed cover to the flooring covers. Contrast the sheets to the other covers so that they can see where they differentiate and not. Remove the door locks. Again, motion detecting night lights. Look at why they might be wanting to get up at night. Reduce clutter and clear pathways. Look at bed rail options if they need assist with transfers or transfer pole. Be aware that there's some safety concerns about some of the bed rails. You want to look at ones that have not got the fall risk of suffocation risk associated with them. If there are fall risk, put a mat on the floor near the bed. Be careful about using electric blankets and electric heating pads because they can't tell when they're too hot. Also, if you're using family pictures, you want them, it says 1.2 meters off the floor, which is 4.5, 5 feet, so almost at eye level. You want large patterned carpet or avoid the large patterned carpets or wallpaper. Contrasting light switches if you want them to use it, right? Looking at different heating systems that are safe. And where possible, you want the bathroom to be seen or easily accessed from the bedroom so that they know where it is and can go there easily. Consider blackout curtains so that you get that sleep-wake cycle without changing for the hours. And looking at clocks that show the night and day as well. So there that clock says Monday morning, and then it will move to Monday afternoon. So that's something there. Label storage or open storage so that things are seen and there's not that anxiety about where is it, can I find it? And an option to pull a blind over the mirror. Mirrors can be scary. And so thinking about either remove it or put a blind over it and just use it when needed for grooming and then pull the blind back down over top of it. Living room, electrical cords, scatter rugs, have smooth floor coverings, but you want them matte and non-slip, not polished, shiny, glossy. Place decals on the large glass panels so that they don't feel like they can just walk straight through those French doors out onto the deck. Protect open fires and heating sources, keep matches, candles out of reach. Consider early using remotes for things like lamps that are behind the furniture so that they learn to use the remote early and are not getting up to try and climb around behind the sofa to turn the lamp on and off. Again, place family photos and items and happy memory things in obvious places. Listening to music memories versus watching TV. Consider lighting and paint colors as we talked about. Keep blinds and curtains open in the daytime and then looking at ways to close them at night. Bulletin board for schedule, cover game mirrors, label cupboards and drawers where the person may be looking for things, and then that day-night clock again for orientation. There's a lot of stuff here. Use signage again. Again, it's the same thing. Lock things up and put them out of the way. Pretending, thinking about if if you want them still to be engaged, or if they're safe to still be engaged, how do you lock the child-safe things, removing the large knobs if they're an item of interest? Again, can you label, how can you keep person engaged, or is it where they're not safe, and removing the access to those? Garage, same thing. Lock it if it's not safe to access. Lock away the dangerous equipment. Secure the motor vehicles. Put the keys in a location that they never were before, so they're not found. If not used, frequently cover, for example, bikes, etc., so it's not so obvious what they are, and allow access with supervision if it's for positive option. With wandering, there are lots of options for that. Black mats in front of the doorway are often perceived as holes and will stop people going there. Same in front of the windows. Doors painted the same color as the walls. Place locks high or low so they're out of eye level. They don't normally go looking. Install window opening limiting devices. Use loosely fitting doorknob covers, but only if the caregivers are present, so that there is a safe way out. They're not left on their own. Secure the yard and have a locked exterior gate. Place stop, do not enter or close signs on the doors or other strategic areas. If you do leave, thinking about monitoring versus if you're expecting the person to be able to exit if there's a fire, you don't want the stop sign there. Okay. And divert attention from the door by placing scenic posters over the door, removable gates, curtains, streamers, wallpaper, or painting the door the same as the walls. Usually we paint it a contrast color. If you paint it the same, it's not as obvious. Keep shoes, keys, suitcases, and coats and other signs of departure out of sight, so they're not as obvious as well. And then have a medical information bracelet with memory loss and caregiver phone number on it. And place it on the dominant hand so it's harder to remove. And there's some resources on cyber, which we can link you up with, and some home safety resources. So hopefully that was a helpful, quick summary. All right, sorry, I don't.
Right. Well, it just dittoed everything she just said. There we go. We're good. So a little bit. So our program is going to be a little bit different and kind of an overview of what we're currently doing in the context of Clark Cowlitz Fire Rescue. Again, our fire district area is really North County, Richfield, La Center, Woodland, a little bit of unincorporated Battleground, a little bit of unincorporated Vancouver, up north of 179th. So again, our program really started out really focusing on that area. And we're looking at our program, again, it is a community assistance referral and education service program. And then we just recently started our falls and environmental risk reduction program, which we call FERB. So it's two separate programs, although we all work together and we're all kind of multitasking different things depending on the need at the time. Someone might have a specialty for something else, while someone else might have a specialty that goes a little bit different than mine. So you can click on the next one. So again, our programs, again, we'll review is kind of what we're currently doing. Our team right now consists of myself. I'm a social worker, a mental health professional. We have a community paramedic firefighter that works with us, and then our community risk reduction specialist who does our FERP program right now. So it's us three. So it's a very small program, and right now we are the only one in Clark County doing a program like this. I think we were talking initially a little bit ago. If, like, let's say a year from now I come back and do another presentation, it'll probably look a lot different because we are looking at expanding. We are looking at incorporating other fire departments and looking at different kind of co-responder models even, because we see the need for that low acuity call as well as kind of what we do, which we'll go into in a little bit. So we can skip over that because I'll talk about all that. So that's myself and our older community paramedic. We just actually got a new paramedic that just started. Josh Haldeman got promoted to captain, and so went back to the line to work on the engines. But we like the picture only because we could show kind of what we drive typically. We do show up in a smaller vehicle usually. It's a little less intrusive. We don't come in bearing lights or any of those kind of things with sirens. We can, but we usually do not. Again, our team is a social worker. I do a lot of the referral intake, resource determination. I do a lot of coordination. I do a lot of advocacy support, as long as everyone else does too. as well as outbound referrals and follow up to other agencies. Our paramedic will do both an expanded role and expanded protocol, so they're able to do kind of non-911, non-emergency calls. They do a lot of physical assessments. They'll do medication, education, reconciliation. I know when we talked about it, initially you were talking about the medication. We go in homes, and a lot of people have way over 4. Quite a few meds. They don't know what they're for. They're just taking them. They're taking old meds. They're taking new meds. So we're able to look at paperwork. We're able to call physicians. We're able to call doctors, hospitals, and really get an idea of what they're supposed to be taking. We've worked a lot with those, the electronic kind of dispensers. We also have medication boxes we're able to give away. We actually have a whole stack of them we got donated to us, and they're really good ones too. So we're able to help people do those, especially folks that might have, issues with their hands and opening some of the boxes, because some of the med boxes are really difficult, even the ones that's supposed to be really easy. We have the push button ones, which are fantastic. And then we have our community risk reduction specialist. She does a lot of our fall risk reduction, assisted device installation. So she'll do installation of kind of simple grab bars and so forth. We don't do anything really extravagant yet. We do look at trying to get medical alert devices for folks. We'll do smoke alarms, fire alarms. Again, I think we were talking about that a little bit earlier today. Every fire station or every fire district should have someone that really does the installation. A lot of the newer fire alarm smoke alarms really are looking at the 10 years, so you don't have to change the battery every year like everyone's supposed to. If you have one of the old ones where you're still changing it every time the clock changes, the newer ones are 10-year batteries. Install them, they're wonderful, they're loud, and they last forever. Go ahead. So again, a lot of what we do is we do respond to a lot of non-emergency calls. So our crews go out, and initially how our program started is our crews will go out for a 911 call, depending on what the call is about. I'm not going to go to every type of call because there is quite a few, but let's say it's a falls call. Maybe the person refuses to go to the hospital, just they needed to help up. They just need to lift up, that's all they needed. So that was it. Maybe the next day they get a call again because they fell again. Crews go out. At that point, the crews are looking like this is an issue. This person needs some assistance. What can we do? So they'll make a referral to us. We have the ability to go out there, not on a 911 basis. So you don't need to call 911 to get us. We can go out. We're mobile. So myself, we have different access to different services than a crew will do. Usually, if a fire crew will get there, they'll handle the situation. The person usually either goes to the hospital or they sign a refusal and they don't go. That's really it. So we have the option then of doing a lot more, spending more time with the person and keeping those fire engines and the ambulances to the crews that actually need the folks that are needing them at that time. You can go on. So again, we do a lot of advocacy. We do a lot of support. We try to do a lot of accountability for our vulnerable community members. It is a voluntary program. So we definitely, what we were saying earlier, encourage folks who might be very resistant to outside help or services, especially if they are experiencing dementia. A lot of times there is some aggression and agitation within that. Luckily enough, because we're the fire department, a lot of folks will let us in a little bit more. Not always, but they tend to open the doors a little more because they're used to us kind of helping or picking them up. Really looking at reduction of unnecessary 911 calls, secondary and inadequate support system. People need it, call 911. It's our first and foremost. But folks that are using it because they fell or because they have a continuous fall, they don't have anyone in their home, they're living alone, they don't have a doctor or a PCP, so they're using it for just general medical care. We're able to kind of work with that. We have seen an 80% reduction of fire department for clients enrolled and engaged in the program over our first kind of initial pilot program over our first 6 months. And again, we really want to contribute to readmission reduction for post-discharge referrals. And what that means is we are looking at, we also work with both Legacy Healthcare, the hospital, and Peace Health. So they are able to refer directly to us for the clients that are being discharged that have inadequate support systems or need some follow-up. It might be medication follow-up. It might be just understanding discharge paperwork. It might be understanding maybe they're discharged with some durable medical equipment and oxygen, a Hoyer, any of those. We're able to help them kind of educate kind of how to use those things also, where the hospital typically isn't able to do that, and or there's a gap between home health starting and the discharge from the hospital. Go ahead. So again, our eligibility is huge. For our crews, we say, if you are concerned, refer. Don't even worry about the eligibility. We'll figure it out from there. We are starting to look at our eligibility for more of our community-based members like the hospital, where we kind of tighten up a little bit, but these are the things typically that we are looking at. Folks that are using 911 quite often, vulnerable at-risk patients, high-risk falls, with an ineffectual or no support system, post-discharge follow-up, folks that just need help navigating systems. There's a lot of different systems out there, and I continue to learn about more systems always, like I'm still learning. So I can only imagine for folks that have never had to deal with that. Again, outreach about disease management, medication management, durable medical equipment. We could do some minor wound care, dressing change. We don't do a lot of that right now, but our paramedic is able to do that. And again, those with unstable discharge plans, if they're discharged home, they're discharged, unhoused. We also do some mental health and substance abuse help assistance. We don't do the actual treatment, but we can link people up. We can get people in the stage where they're ready to want to get help. We have an example. We had an elderly gentleman who had a history of falls and a history of alcohol use, ended up going through a glass door in the shower, suffered some minor injuries. So working with them, we were actually able to get him into a treatment, and actually he's doing really well. We got grab bars put up because he still had a history of falls and so forth, but definitely a success. Go ahead. Again, our service area typically right now, when we look at our district, our fire district, as I said before, but those district areas don't mean anything to somebody outside of those districts, because unless they come to you, you don't have no clue, because they're shaped weird, they're funky. So right now we really say our service area is Clark County and Southern Cowlitz County, which is that part of Woodland right there. Our funding is not through the actual fire department. Our funding is through different grants and different agencies. So we're able to kind of go outside of our fire district area where the tax dollars pay, because our program is funded separately outside of that. Our first and foremost would be to our district area, but we are able to go outside of different areas. We are pursuing cooperation with other fire agencies. We're typically a Monday through Friday program. For the summer, we've been doing Monday through Saturday. And again, we accept referrals at all times, but again, we might not be able to get to them depending on the time of day, depending on when we get it, holidays and so forth. Go ahead. Our FERP program, again, is the fall risk reduction program. Again, we use a steady program to reduce risk of falls for older folks. And again, really that's looking at screening, assessing, intervening, reducing risk of falling in older adults. We do not do the OT portion and all of that stuff. We refer out to those. Those are the expertise. These are how to do all those. We will tell somebody, use your walker. And somebody might be walker resistant. It's like what you called it earlier.
Abandonment.
Yeah, walker abandonment. They just don't know. So we'll try to actually help people engage in that decision where they actually know they need help. We run a lot of calls on folks who don't want any help, don't see a need for any help, sometimes are experiencing dementia or other things without a support system, and really are starting to kind of not function as appropriately and getting themselves into danger, wandering, falling. We have a lot of falls outside, unfortunately too, especially in rural kind of Clark County up north a little bit more. So again, some of that might just be educating them to get to the resources and finally accept the help from an OT to go in that. We've gone into homes sometimes where the OT is working with them and we're able to work with the caregiver or just about accepting the changes that are going on and kind of making it kind of a multifunctional thing at times, which I love when that happens. It always makes me happy to see a lot of folks coming in there and helping out. You can go ahead. Some of our fall risk clients, again, we do look for hazard mitigation in the homes, as you talked about before, especially clutter. We run into a lot of homes with clutter. So it's really about getting people to start moving stuff. We can help in that. We don't mind. We can pick up a box if need be. We can move a rug. But a lot of times we go into homes and unfortunately they are extremely cluttered. And so getting people to start kind of understanding that process of removing items, going through items, what they're willing to get away, that does take a while to do. So we're able to kind of start that talk with them, especially if there's been multiple falls in the home. We're able to kind of do grab bars and those kind of things. We've installed bed risers and bed lowers. We've helped install kind of the shower chairs as well as the toilet kind of things. We haven't installed any of the fancy disco lights, so we might have to.
You need to get
I
some
like
of
that. I like that. So looking at those kind of things, sometimes we have some equipment that we have on our own. Sometimes the person has to buy them, especially if they want a piece of, I don't want to say more fancy, but some people want some very high quality, very, not quality, but very decorative design type things. We don't have any of the bright green ones either. I like those. But we do have a lot of people who are like, no, you don't put that in my house, even if we have just the regular nickel looking ones or the regular like white ones. So again, sometimes they'll get their own. So we really are working with people where they're at, what they want. We will encourage people and teach people and educate people about all those things. But again, if they're refusing at all times, it's on them. We'll do our best to kind of continue though. We'll call them up and kind of bug them about it. We give people homework to do about different things. And again, we do for our county or for our district, we do smart alarm installations. Again, depending on where you reside, it might take a little bit more. We've talked about Vancouver a little bit. Sometimes Vancouver, you have to kind of find out who's doing it. If need be, you're more welcome to give us a call. We can try to make a call for you. If need be. You can go ahead. I know, I don't understand why we have one right there. I'll have to fix that. Again, we do have, we're kind of unique again, because we are part of the fire department that usually folks will let us in there. We do have access though to just those random falls that people have they might not tell anyone. Even if they call 911, the crews go out, lift someone back into their chair or bed, refuse to go to the hospital. You know, a typical provider may never know those calls are happening. We're able to kind of really review those and have that very, discussion, even if they haven't, don't know anything about our program. We're able to go in there and be like, you have called us 3 times now over the past couple of days. What's going on? And start to have a discussion where they might be able to finally accept the help or assistance, and then we can make the appropriate referrals from there. Again, because we're part of that, we have the fire marshal services that we could do home checks, assessment checks. Our fire marshal does go out to homes, checks around homes for fire prevention, making sure making sure heaters, all those kind of things are spaced out, because that's our first and foremost, of course. And then our CARES team works in conjunction with the FERC team. So really, as I said before, initially, we're all kind of one, although we have separate programs just due to the way we're funding and so forth, which I'll go into in a minute. Go ahead. And again, our program growth, we really are looking at gathering data right now, what that looks like. Some of those statistics that you had mentioned earlier were really kind of interesting. I'd like to see kind of how they compare to some of ours. But really looking at kind of where the need lies within it. We right now look at kind of area, we look at referral source, we look at which program we're in and so forth. We're looking at things. We are deepening partnerships. We work closely with SWATCH, which is the Southwest Accountable Community of Health, which is the ACH for Clark County, Cowlitz County, and Skamania County. They are one of our primary funders right now for our program, at least the CARES program. We look at post-discharge follow-up with the area hospitals. We do have funding. We're contracting with them. We are looking at meeting with Kaiser and hopefully developing something further for the entire county. We do work closely with ADSWA, which is the Area Agency on Adults with Disability of Southwest Washington, for our fall risk reduction program, as well as our medication education program that we're able to do. So we're able to go through the county if need be. We've gone to a couple of the more senior kind of living facilities and different areas and talk about medication compliance, what it means. People have questions. They're more than welcome to talk with us. We've also helped with our COVID programs in the area, both as a vaccination partner, so able to help with that, and education, as well as our Connect Care Washington program for all of Clark County, which helped people get food and supplies while they were quarantining or isolating, especially during that peak in the COVID time. So again, we were helping with that. Go ahead. Again, those are our initial contacts, myself, as well as Maddie Pearl, who is our fall risk reduction specialist. I don't have our community paramedic there. Typically mine, though, I'll get everything to him. Again, looking at that, though, I think that should be the last one, if not the questions, if I'm not mistaken. Yeah. So looking at it, though, is our program is really unique in that kind of where we're at right now, especially when it comes to referrals and so forth. And I always want to make sure people are aware of that, in case they're like, "Ooh, we need that right now for someone." They live in Washougal, or they live in Camas, or they live down, a block away from here. Just because right now, the way our funding sources work is we are going through SWATCH for our main program, which helps fund our area and our service district area. And we have the hospital referrals that are able to kind of refer, and then we get the referrals from ADSWA right now. So we have different kind of resources coming in. We do take community referrals on a limited basis right now, directly from the community directly, just because of our limited abilities. 3 people for the entire county. We're not really able to do that yet. In the future, we really are looking at how we make that happen. The Southwest Accountable Community of Health, so SWATCH, has what's called the Pathways program. I don't know if you guys are familiar with that. You are. So really, it's working with them, and they're able to kind of work with multiple agencies throughout the county, and give them, or not give them, But enroll them in the program and have a community health worker working with them, going through different things, depending on what their need is. It might be homelessness, so it might be housing, it might be just getting a doctor, it might be getting insurance, it might be something else. It might be specific therapy or something else they're looking for individually. So they have folks that are able to do that. So we are connected in that system to be able to make those referrals. Eventually, we are going to be receiving referrals from them. So really, at that point, they could come from more of the community members throughout the whole county. We're just sort of not there yet. This is really our second years, 2.5 years right now of really looking at the program and growing it. We are looking at contracting again more with the hospitals than we are right now. We're hoping to further develop those programs. We are also looking at what a co-responder type of program could look like for those non-emergency 911 calls that we do come in, such as someone's just not feeling well. How do we help them out? Do we need to send a whole ambulance and fire crew out there? Or can we go and do a screening and then decide upon that point how to do it? So we're looking at different things in the future. We're just not quite there yet. So I always want to put that kind of caveat down to our program because I think we're really doing good work. And I would love to see it expand throughout the county more. But we do have referral ways right now that we're kind of getting just for our own sake of staffing.
So if someone falls
Mhm.
and is a frequent faller and their care partners are not able to get them up, can you call you instead of 911?
No, because of area right now, because we are not an emergency response unit right now. So we are a non-emergency response unit. So if somebody falls, you can't get them up, call 911, get them up. What we'd like to see then, let's say they have multiple falls, is hopefully getting connected in with a system such as area agency and whatnot, and have them refer to our fall program, and then we can kind of work on that end. We pick people up before. It's not true. We pick people up, but we're not there as a response to pick people up and do that right now as an emergency basis. We are a non-acute call, especially if we're out of our area, which could take anywhere from 40 minutes to move down here.
Well, when you were describing that your team is 3 people, you can,
It's a little small.
and it's a little far apart.
Yeah. Luckily enough, so we are located actually over at the Battleground Station in Dollars Corner right now. That's where our station is located, 26, but we do have stations. We have 6 stations kind of scattered throughout right now up in the northern area. So we have the ability to kind of travel and so forth. But when it comes to the emergency response units, yes, please call 911. If you have other questions though about things, we can help out, is whatever we need.
Would emergency response, would 911 ever contact you?
Not yet. Hopefully in the future. We are looking at how to make that possible. We are not a non-response unit though currently. So CRESA, when they get the 911 call and it goes into CRESA, the call gets logged. They'll dispatch the appropriate folks, so whoever is local and around and closest to them, depending on where they're at. So if it was down here, it could probably be unit, it could probably be number 3, which is right down Mill Plain. It could be, there's one up here too. I can't remember all their stations are. So it really would depend on kind of who's going into the home at that point. What we would like to see again is then hopefully whoever's working with that particular person, if it's a caregiver, if it's an agency, for them to get it into the system, and that system then, right now it's just AdSWAT that would refer to us, but hopefully in the future we'd look at other systems and other folks being able to refer to us depending on what system they're in.
Okay.
So we are looking at in the future of reaching out, getting more of all of Clark County. That'd be our goal anyway, right now.
So if people are continuing to fall like that, they can get outpatient therapy services, mobile that will come to the home, so the caregiver could call and request that. A lot of people get confused with, that have to be home health. And home health has such a long waiting list right now. It's so hard to get into. So, I can be there within a few days usually.
That's awesome.
Yeah, might get too busy. But there's a lot of outpatient mobile services now that can come to the home that don't require them to meet the criteria for home health. And so that's a big barrier often that people don't see and don't get over. It's very different. It's an outpatient service using, generally Medicare Part B or replacement plans versus under Medicare A for home health.
Yeah, there's a few agencies that'll do that, that'll go in, they might do a PT and OT combination, they might have someone else that go in, but it's not home health necessarily, but the folks are going in there there's eyes on, they're doing a bunch of different things. We try to refer as much as we can to outside agencies to do different things that go into homes, because we typically, don't keep a client on forever. We usually do just to get them to the next step where they need to be and making sure they're connected to resources, although we've had some last quite a while too.
And it doesn't necessarily need to be agencies. There's some of us in private
Yes, I'm sorry.
practice as
Yeah.
well. that do-
I call you an agency. It has your name.
My
You're an
agency,
agency.
there we
You're an
go.
agency.
Yes, and so I have a couple of PTs that do that as well. So there's,
Well, I was gonna ask for that clarification. I mean, who are we talking about if people don't qualify for home health?
so then you're looking at who provides outpatient services in the home. And so there's a physical therapist that does mobile Part B, well, outpatient will come to the home and also has a clinic. I do the same thing from an occupational therapy perspective. So one of her name is Rehab Specialties is her business. I'm OT Lifestyle Solutions. Then there are some home health agencies that will use Part B, but they're so overwhelmed right now with their home health that it's often difficult for them to get to those situations.
And then the other thing really is just making sure someone has, a provider or caregiver of some sort, especially when they get to a point. That's one of our big things, especially with our folks who might not have anyone in the home at all, checking on them. So looking at how do we get care providers? There's private pay ones, there's ones that go through the state, there's ones that go through Medicaid, there's different kind of avenues to go. And sometimes that is a task of working and figuring that out and hiring someone, especially, it's been difficult lately of having folks.
It's so
caregivers.
hard to get
They've been,
carers.
yeah, they've been pretty backed up. I know that.
But yeah, I've worked with people the same
Yeah.
way, kind of trying to put that together and look at where can they get a case manager? Can we pull this together? What does that look like? And then who are funding sources? Because a lot of this equipment we're talking about, sometimes insurance will cover some of it. I just actually had insurance pay for a ramp for a client for me.
Nice.
Yeah, I just outlined to them what the expense would be if they didn't pay for the ramp, and they suddenly realized that the $3,000 for the material was way less than the emergency room visit would be. So we were able to get that done, but I had to work with case managers to do that at the insurance company. So it's possible. You need someone who has the skills and the expertise, though. Not everybody has the ability to do that. So.
Yeah, and we really, we talk a lot with doctors. We try to encourage them to prescribe, durable medical equipment and get them in the home. What does that look like? We'll help them set it up. I don't care about that, especially if you're working with care managers or the insurance companies or any of those. But it can be difficult. We also give out these, and you guys are more than welcome to have some of these. They're just medical information sheets. Everyone should have some sort of similar thing like that. We encourage it to put on everyone's fridge, and really it's your medical information. It's, the meds you're taking, anything else. It could be, it could be a pulse form. It could be any of those kind of things, but we encourage everyone to have something like that on your fridge. Just because when EMS, no matter what district comes in, the first thing they're going to want is that information. And if you have it all kind of combined, neat, succinct, it helps a lot. You can get the best care for someone.
And in terms of DME,
Yeah.
some of the problems with getting DMEs prescribed is that letter of medical necessity
Yeah.
and being able to argue. And that's why having a therapist do it
Yeah.
gives you extra clout. And I go in and take pictures and measurements, and
That's
I
awesome.
send a report that way. And I have rarely got things denied lately.
Nice.
So,
No, that's awesome. You can get, yeah. So the DME, again, just this durable medical equipment. Just as
so it could be lifting systems, but depending on who the funding source is, it could also be shower chair systems without having to do a modification. So, there's a range of options that are available.
And then, again, does everyone here know what a pulse form is? Okay. Just so I don't have to repeat it. I encourage folks, depending on where people are, just because I always like to give people, I want them to be able to provide and understand the care for themselves and be able to dictate that. So we always encourage that, especially kind of in those early stages, dementia, whatnot, to understand whether while they still can and still have the capacity to be able to do that, make decisions about their own healthcare when they can, and empower people to be able to kind of make those decisions. We are a big believer in that. Again, if our crews go in and we don't have a pulse that says about do not resuscitate, we will do everything we can. But if someone's wish is not, we don't have that written anywhere, unfortunately, we can't do that. So just something for you guys to know about our crews when they go in.
So when is someone considered a fall risk?
So there are assessments that we can do that actually based on the data, gives the percentage of chance that person will fall within the next few months. But realistically, the biggest thing is, are they catching themselves off balance? Are they catching themselves confused at times? Are they dizzy at times? Is their vision changing? And have they had near falls? The Medicare criteria that they used for the implementation of their quality plan for managing falls as they brought out the study was 1 fall with an injury in the last 12 months and 2 falls without an injury in the last 12 months. That was their criteria, not of a fall risk, but of someone who had fallen and needed a standard plan of care to address that. So.
Yeah, we call in every fall, at least for our service area. We will literally call everyone if they've had just 1 fall. Again, when we go in though for other things, we're always evaluating for fall risk. So, what kind of meds you're on, what are the side effects of the meds? Sometimes we'll just we watch people walk and we'll see how their gait is and how steady they are on their feet. We'll ask those direct questions about, have you ever fallen and just been able to get yourself back up, but just kind of fell? And a lot of people be like, oh yeah, but that was just because I was off balance. So they won't say they fell, they just were off balance and slipped or whatnot. And so you get a lot of that, of those non-fall falls, where, digging a little deeper with someone about what's really going on. Again, we have a lot of ones where it's medication related, either overdoing the meds or just not understanding the side effects of the meds. And we have some that, kind of have a lot of falls due to that. And then we've been able to help them change their meds if they're doctor and whatnot, and the falls, they're gone. And so we've had that also. So really, we kind of run the gamut of fall. When it comes, defining, again, we're going to help folks and we're going to assess for that in every client we go out on. Even if we've had some young folks, we've had different medical conditions too, in their 20s that have had some falls too. So we can even assess for that.
I didn't understand why using a mobility aid would increase chance of fall, especially in males. I didn't understand that.
So part of the data there was looking at the fact they were a fall risk already, and they weren't necessarily using the right aid, or they weren't using it correctly because it was given to them too late generally, and then trying to learn that new habit and that compensation. So usually getting tripped up on it, forgetting it and leaving it somewhere when they should have had it, all of those kinds of
Because
things.
my thought was, well, wouldn't that help them to keep them from falling? So I didn't understand.
So we've had some that, again, refuse to use the walker, but they use a cane. Again, they're using something, but it's not enough for them. Some folks get a walker, then honestly, they don't know how to use them. It's not just holding onto a walker and using it.
Yeah.
So our OTs, like when we've seen them work with them for, like,
Absolutely.
I'll even learn. I'm like, ooh, let me watch.
Yeah.
Not just from locking it, but from how to move it, how to go from a sitting to a standing with it next to you, where to put it. You would think it's just very simple, everyone can use them, but there is a way of doing it, especially if you're already not very balanced or weak already. And that goes back to some of the arm weakness too, is there is a lot of that balance in the arms.
The memory, the
Yeah.
cognition, and then it
Especially
also
with
goes
dementia.
back to the fact that they've often either been given it and then discharged straight away, and so they don't know how to use it in the real environment. A hospital floor is very different, to where you are there. The other thing is often they grab grandma's that has been out in the garage for how long, or such and such brother had one when they had surgery and they hand it on, right?
Yeah.
And it's not the right size, or it's not the right one.
Can you address the front wheel walker and the 4-wheel walker, for people with dementia?
Yeah, and then you're looking at some of the higher walkers. So each of them requires a particular level of balance to use it first. And then it also requires the cognition to be able to operate the brakes or not operate the brakes. And when you're talking about a 4-wheel walker. So that's all the assessment piece that goes into that, is the movement planning, the cognition, the memory, the balance, the whole piece. And it's not just you need a walker, right? And then it's training. Where is the capacity to learn at this time and develop those habits? And is it still there that you can add those things? Because that's going to contribute to whether they're safe or not with that equipment. And then, it may be very different in the daytime to it is at nighttime. So then looking at how do we address that?
Yeah, we've worked with a lot of folks too who might be using one, but they're just going a short distance. So I'm just going right there to the fridge. I have if I fall, I have my table to hold on to. And so they have all these other ways of handling it versus doing that, where they go too fast and forget something and turn around, and just that act of moving, get them dizzy and they'll go to the ground. And so it's telling people, especially if they haven't really needed this in the past, to be able to start to accept that process, and that aging process, and or that weakness finally, where before maybe they were, I always do things for myself. I've never been able to have to rely on someone, and now they're having to. And so being able to kind of cross that, we work a lot with folks, especially in the aging population, that have, this is the first time really all of a sudden being dependent on other things or other people, and they're not doing very well with that.
Do you have a list of I've fallen, I can't get up aids that you recommend, or resources for that?
I do in my head and on my, what we used to say was a Rolodex, but on my computer system. But it's so individual.
Yeah.
It really depends on, are you by yourself? What are the skills and the abilities that you have? Who's there to assist you? What are their skills, abilities, and size? And what's the environmental context that we're talking about? And it's so different. It's, we were just talking about ADA grab bar prescription. It's basically, if you do that, it's like prescribing hospital socks, right? One size fits everybody, fits nobody, right? I mean, that's basically, so it really is, there are some general guidelines that we use, but it really is dependent on so many factors. And that's why the skills of a therapist involved in that, because you have to consider the vision, the cognition, the physical ability, the caregiver, the environment, the piece. So being able to just give you a one-off may put you more at risk.
So a referral would be good, an assessment and then recommending it.
Yes, yeah.
I don't really have a stake in which one. We highly encourage them with folks, especially if they are at fall risk, especially if they don't have anyone around. We meet a lot of folks who do live alone in a variety of capacities, in a variety of buildings and trailers, manufactured homes, to huge, mansions. We still encourage them because we've seen them, and they come into all Crest 911 a lot. Even if they're a false call, I'd rather be a false call, like a mistaken activation. I'd rather have that. They still would encourage it.
Definitely, and particularly if you haven't worked on that full recovery and haven't assessed the injury, absolutely, that's definitely the key. But then let's move on from there and look at how do we prevent it, or how do we deal with it in a way that isn't always a 911 call.
So Sam gave us a great example of a success story with medication.
Yeah, that was a medication one,
Right.
where it was.
So Sue, have you got a success story that you can share with dementia and fall risk?
Yes. So one of the things was actually the place was really flooded and the floor surface was uneven. And so the working with the person to look at habits and procedures, and with the caregiver to look at how to maintain that cleanliness. And then there were grab bars and shower options, and went from falls every few days basically to none in the last 3 months. I have a gentleman right now that I was just working with, us talking with Parkinson's, and again, your shower glass door. When I first met him, he was pulling himself up off the toilet using the glass door on the shower. And so last year, when we had those 116-degree temperatures, he said it was the temperature that cracked and shattered that glass door.
Yeah.
But it really was the repeated pulling on the door that stressed it, and the temperature was just the final straw. And so, we've been, again, just even a simple 3-in-1 commode over the toilet, then just changed how his toilet transfers occurred. No expense, I got it from a carrying closet. Installing a transfer pole right beside the shower door so that he could step in without grabbing onto the shower door to stress it. So just some simple things like that he was able to do that really then reduced the risk of fall, the broken glass, everything else.
Yeah, I don't like glass doors in bathrooms.
I don't like glass doors in
It's like
bathrooms
an
either.
old 1970, 80.
My first step is often remove them, but we did find some resistance to that. The reason is, and it's the same with towel bars, people, you grab for something that's nearby, they're not meant to take your weight and stuff on that, so then you're always at a risk.
Can you address the suction
bars?
So
The non-drilly ones.
the non-drilly ones. Yes, no. So I don't recommend the suction bars. I do have a set in my kit, and I use them to locate where is going to be the best position for people to put suction bars. The problem is the suction gives way as the temperature varies, as the surface varies, and so they're not safe. Now, my daughter was 24 when she had back surgery. She put 2 up in her bathroom. She checked them every time before she used them, et cetera, et cetera. They had the ones with the light indicators on them to make sure the suction was good. That isn't the situation that we're talking about here. And so they give a false sense of security. They're also very likely to slip, particularly give way on the bathroom surfaces and even on walls because there's not necessarily a smooth surface. So again, they're not safe over the long term.
What is one thing you both want everyone to know?
You know, I think with anything that we're doing, especially, I mean, especially in our capacity, because usually, you know, our program really initially started from 911 calls. So whatever happened already happened. We see a lot of these things though, where some preventative work can really go a really long way. From first diagnosis of something of an issue, from recognizing the issue. But that work ahead of time, whether it be just going to a doctor and getting a checkup, can really do wonders. I mean, it can do wonders in the home for falls, kind of that, you know, dementia, if it's that early stage of dementia, being able to start those routines now while they're still kind of aware of what's going on enough to be able to kind of both choose for themselves what they want and how to do a lot of it, and give them some autonomy within their own kind of world and their own healthcare, but also start those habits early. I think, you know, those are my big ones. I think it's just really that preventative care. It really helps. And you can always have preventative with fire too.
Yeah, I have to second that. Starting the habits and routines early is good. I think don't be afraid to ask for answers in questions. And if you don't get the answer you want, keep pushing it. For example, I was gonna say a young man, but he was 72, had a live-in caregiver, and he was getting scared to get in the shower because he was fearful he was going to fall on his caregiver. So he stopped taking the shower, right? Because the caregiver was his living caregiver. If he got hurt, there went his whole living situation. And so his case manager called in home health therapist, and he had a sliding tub transfer bench, just a very simple one. And the home health therapist said, well, that is the Cadillac. That's the best you can get. And you know, his case manager then called me and said, well, this hasn't solved the problem. You know, that's where he's still at. And so when I went out, I was able to identify, well, his sitting balance is deteriorating. He's sitting on this little seat. There's no support for him whatsoever. And it puts the caregiver at risk. And so we were able to actually get his insurance to pay for a very different system that allowed the caregiver to reel him in there and slide him across. And so I'm gonna say, if you're not getting answers, keep asking. You know, there are people who will keep looking and find them, and we were able to do that. So he now was back having a shower and nobody's getting hurt, and the caregiver just bought a new home and they moved, and we were able to take the whole system with them, and it moved better. So you know, there are potential options. So if you don't get answers and you still have a problem, keep asking.
That's a great story.
It brought tears to my eyes.
So my very last question is, can you ask for a fall risk assessment before being a fall risk? Would
Yes.
it be recommended to do that assessment early? And Sam, you kind of addressed that.
Yeah, well, we go in, I mean, we try to do it with everyone we're working with, because we know it's happening. Whether or not they call them a fall or a slip or just unbalanced, you know, it's bound to happen. So ask, you know, get the assessment. It might not be, maybe, I don't know if you guys do full blown assessments even in just pre.
Yeah, we can.
But we're gonna gotta do the real kind of our assessment within that, to where we think, oh, maybe you could start now looking at those things. Whether or not they're open to it, you know, some people are and some people aren't. We'll get there, but we'll work with people to get there. But yeah, it can't hurt. Same way we do our fires. People have a lot of bushes around. We'll have our fire marshal come out, you know, and look at the home and say what needs to be fixed, what needs to be changed. We're all about prevention. I'd rather things not happen.
So I would say on that, if you're noticing that you're having trouble getting out of the chair, getting up consistently, if you're noticing that you're stumbling a little bit, then it pays to call and let us do an assessment to look at what's going on. You know, because sometimes without realizing it, and particularly as people have been reducing their activity over this period of COVID, lower extremity strength, upper extremity strength, those vision, the interaction, moving around objects is all changed.
Last question has to do with exercise. Is there a particular exercise regime that you would recommend? I hear about Tai Chi all the time.
Tai Chi has some good studies for it. There are about 4 different recommended research-based programs for people to prevent falls. There's one I use for people post-stroke. There's the Ortega one that came out of New Zealand. There is one that is Step Up that's done here. There's also Tai Chi has a lot of research with it. So there are several that have research. And again, it really depends on one, what will you do? You know, I think that's the key is what is it you're going to do, and finding something that matches your interest and your ability to do that.
Thank you very much. So thank you guys for coming
Yeah,
in the
well,
last
thank you very
minute.
much.
It was awesome. I learned a ton of stuff. And I wanted everybody to know that next month on the 30th, we will be having our home care agencies and placement agencies in a panel discussion so that you can find out what they offer and when might it be time to place your loved one. The very hardest question of all. So thanks, everyone.
And I can have some of the medical sheets here, you guys. If you would like, you can take as many as you like. Take 1, 12, I don't care. And I'll leave some of my cards here. You're more than welcome